Yeah, sir.
Okay, started recording. Is my screen full now? Full screen?
Yeah.
Yeah, sir.
So good evening, one and all. I am Dr. Swapna, Assistant Professor of Neonatology, Niloufer Hospital. It's my pleasure that we are presenting a case. Our DM resident, Dr. Kalyan, will be presenting 3 cases which are presented with asymmetrical faces to our NICU. So, Kalyan, we will start in another 1 minute, no?
Yes, ma'am. Yes, ma'am. There
Yeah.
are about 30 participants. I'll start in another minute.
I request all others to mute yourself. Now we can start?
Yes, ma'am. I'll
Or
start the
we'll
presentation. We'll start it. I think they'll join slowly.
Yeah.
Yeah. So good evening, everybody. As ma'am said, we'll be discussing asymmetric faces in newborns and associated dilemmas in diagnosis and management. So here we'll start with case 1. This is a baby of X. It's a 30-week preterm baby. A baby's birth weight was 1.1 kg. It was referred at 3 days to our hospital for preterm care because they had financial constraint in the private hospital. So coming to their antenatal history, a baby was born to 24 years old mother without any medical complications. It was a second and birth order baby, and no other antenatal history was significant. So you can see all that regular antenatal checkups were done. It was a good case, a booked case, and no infections, PI, GDM, nothing. So antenatally there was nothing significant. And coming to the natal history, baby was delivered by spontaneous vaginal delivery at 30 weeks. There was history of premature rupture of membranes for 2 days. Antenatal steroid status is not known. Baby required resuscitation at birth. Baby required bag mask ventilation at birth. Abgas for 1 minute was 4 and 5 minutes was 7. Baby required early rescue surfactant therapy and was extubated to CPAP prongs on day 2. And baby was referred on day 3 in view of financial constraint. At admission to our hospital on day 3, baby was shifted on low flow oxygen, and it was shifted for almost 100 kilometers. And SAS score was 4. So we started the baby on bubble CPAP using Hudson prongs. Baby's head circumference was 27, which is in good centile, lying between 10th and 50th centile. And clinical examination was normal at admission with no evidence of any facial malformations. And the screening NSG as per the unit protocol on day 1 or day of admission was normal. So on day 6 of life, this baby had developed shock and sepsis. And baby's investigation showed a severe thrombocytopenia. Initially, it was 23,000. Later, the least count dropped to was 18,000. The blood culture grew candida. Baby was given antibiotics. Baby was given platelet transfusions with all the supportive care. Baby has improved. And NSG, in a day or two after baby had gone into shock, we have done, and this was a picture of the NSG. As you can all see, there is a good, well circumscribed, nice intraventricular hemorrhage. Parenchymal hemorrhage, and probably in the region of thalamus. So there was a thalamic bleed. And the thalamic bleed in this baby could be probably because of the hemodynamic instability, where baby had to undergo, there was shock and baby required inotropic support. All that hemodynamic instability would have caused this. And now, after the treatment, baby has improved slowly. The shock has resolved. And on day 12 of life, we noticed this facial asymmetry for the baby. So you guys can all see there is no forehead wrinkling for the baby on the left side, and baby's eye is not closed on the left side, and there is no nasolabial fold on the left side. So all this will go in favor of left-sided element palsy. But and next to the neurological examination, other cranial nerves were normal, tone was normal. There was other examination was all normal. So what do you think it is the differential diagnosis for this baby? Actually, the resident on the duty was very happy because there was a bleed and there was this, so there was some correlation. So, but were you happy with that or are you not happy? I would like anybody to volunteer and give you a differential diagnosis. Do you think the bleed is responsible or anything else responsible for this baby? Probably you can unmute and speak.
Yeah, residents who want to give a differential diagnosis can unmute yourself and discuss.
Vignesh, allow them to unmute. In the meeting settings, there will be an option called allow themselves to unmute if required.
It is on, sir.
Yeah, okay.
Yeah. Yeah, anybody want to give? Like what would be the cause of causes of element type of facial nerve palsy? Could bleed cause such a picture like this, thalamic bleed? Will thalamic bleed will cause element type or UMN type of facial palsy, if at all if the baby is due to thalamic bleed?
Okay, so like the ma'am said, probably I'll continue discussing, ma'am. The bleed was actually intraparenchymal bleed in the thalamus region. So if that had caused facial palsy, the palsy would have been UMN type. But this baby has an element type of facial palsy. So where the etiologies are different. Now, do you all agree with me? This is acquired. I mean, this has developed on day 12 of life. So the reason should be acquired palsy. It's not congenital. So what could be the reasons for acquired facial palsy? My presentation got stuck. 1 minute. I'll just stop it and share it again.
So causes of acquired facial palsy, could it be due to infection because this baby had a shock, candida sepsis, or severe thrombocytopenia? Will sepsis cause? So we also
Yeah, so our differential diagnosis could be meningitis because this baby had sepsis and shock. Meningitis can cause facial palsy because the facial nerve comes out of the cerebellopontine angle. There it comes in contact with meninges. So any inflammation on the meninges can put some pressure on the facial nerve and cause this palsy. And IC bleed causing compression. So the IC bleed or the parenchymal bleed, what we saw on NSG was in thalamus, but we do not know, we cannot see access all the areas through our ultrasound. So probably there was IC bleed somewhere else which could have caused this. Another thing is ear infections. Ear infections are reported as early as 2 weeks in neonatal literature. So that could have caused the facial palsy or anomalies to the facial nerve. So like bony descents or such things would put the baby at risk for development of facial palsy early because little amount of inflammation can compress the nerve and cause it. Or last but not the least, when you have ruled out everything, it could have been idiopathic. So in this baby, meningitis, CSF was done. It was normal. We have even sent CSF for viral markers, PCR and serology to rule out aseptic meningitis, and that was also normal. CT brain was, other than that resolving thalamic bleed which you've seen, rest of it was absolutely normal. We have done a ear examination done, which was normal, and MRI brain was done. That was also normal. So, I mean, we are just left with nothing else as diagnosis of exclusion, labeling it as idiopathic Bell's palsy, idiopathic facial nerve palsy. Okay, though idiopathic, steroids were not used for this baby because baby was septic and baby is a preterm baby already at risk for neurological injury. We have obtained a pediatric neurologic consultation and sir has advised just a facial massage, and the baby started to show some signs of improvement after 2 weeks with a resolution of lag ophthalmos and partial appearance of the nasolabial fold. This baby was just discharged 5 days ago. We are waiting for the follow-up and just to see how the baby recovers. And this brings us to our second case. This is a baby of Y. It's a preterm IUGR baby. It's a 34-weeker. It was born with a birth weight of 1.4. It was referred at 5 days of life to our hospital with the chief complaint of facial asymmetry. So antenatal history, this was born to a primary mother, 21 years old. Mother had PIH, was on oral antihypertensives. Mother had oligohydramnios, and like natally, baby was born, delivered in view of impending eclampsia. Antenatal steroids were given. Birth weight was 1.4 kg. Abgas were good. Baby required CPAP for 2 days. The interface for CPAP was not known, and the baby had an episode of seizure on day 2, which was attributed to hypocalcemia. But on day 5 of life, they have noted a facial asymmetry and referred it to us. So this was the baby at admission. This is a baby. This is actually not at admission. We have taken this picture later, but this is a baby where you can see this baby also has a left side one. So left side element palsy. You do not see the nasolabial fold. You do not see the forehead wrinkling, and you can see clearly that lag ophthalmos. And except for this, rest of the examination was absolutely normal. So what could be the differential diagnosis in this baby? Any inputs now?
Whoever wants to discuss, they can admit and give some inputs.
Any you can just,
what was the mode of delivery? What was the mode of delivery?
Mode of delivery was LSCS, sir.
And was it noticed since birth, or any progression, or it was
It was not noticed since birth from their history, sir. They say baby was normal at birth. On day 5, they have noticed it and they've sent it to us. Parents are not aware because right from birth, baby was in NICU because baby required CPAP. Later, baby developed seizures. And in our referral form, it was written it's a de novo onset facial palsy.
Were there any neuroimaging done, because there was seizure and any other small bleed, or like in the previous case, did they do any screening ultrasound to differentiate any other bleed in the brain?
Till the baby came to us, nothing was done.
Okay, then meningitis was also not ruled out. No sepsis were basically meningitis, and neuroimaging was not done for the baby.
No, sir.
Okay.
Okay, fine. As sir said, probably meningitis, neuroimaging, all this, what we have discussed as an acquired etiology of facial nerve palsy in the previous case, all that will also cause this. But most importantly, okay, again, there's a problem with this. Most importantly, because the baby has been in NICU, the parents are not aware of the history. And similarly, the doctors, you're so much busy doing core neonatology, ventilation, all that, we tend to, pick up the subtle signs. When the baby is on CPAP and the baby is on ventilator, it might be difficult to appreciate these findings. So in this case, we are supposed to consider congenital facial palsy as also one of our differential diagnoses because the presentation was very, very early. All the literature, no literature had showed congenital facial nerve palsy, coming, acquired facial nerve palsy coming this early. The earliest was 7 days. So this baby was picked up at 5 days only. So the congenital could be traumatic because of the birth trauma, or it could be syndromic or developmental. And we'll see how do we rule out all that. So traumatic, it can be traumatic because it's a primary mother. There was oligohydramnios, and that's a preterm. So it is just not LGA baby, which is a risk factor for traumatic delivery. It is, for traumatic facial nerve palsy, preterm also because of their abnormal positions and lack of soft tissue, so that their facial nerve is easily exposed to injury. And it is not syndromic because there were no congenital anomalies in examination. It was not developmental because probably it was not present at birth. And the imaging, what we did, we actually did not do an MRI for this baby, only CT was done, and the CT did not show any abnormalities. We ruled out infection. We did a CSF that was absolutely normal. Ear examination done by an ENT specialist was normal. Hearing was normal for this baby. NSG and CT was normal. And idiopathic, it is again the diagnosis of exclusion. So believing the referring consultant that it was not present at birth, so this could be again an idiopathic facial nerve palsy, which is a diagnosis of exclusion. So we started a course of steroids for this baby, prednisolone at 1 mg per kg per day for 2 weeks. Baby showed partial resolution of facial palsy after 1 week of steroids, and the baby, which was followed up to 2 months, showed complete resolution. So first baby, we did not give steroids. Second baby, we gave steroids. What is the role of steroids? All that we'll be discussing later when we come to the discussion part. This is another case. There's a baby of Z. It's an inborn baby only. It's a 37-weeker. Again, it's a Ayurveda baby with a birth weight of 1.9. Abgas were good. And the resident noticed the baby had deviation of mouth while crying, but no asymmetry with the baby was calm. So the difference between this baby and the other baby, as you can clearly see, this baby has a good nasolabial fold, even though the face is, even though it is deviated, the mouth is deviated, and the forehead wrinkling is also present. So this is not facial palsy. So clearly we can make out this is not facial palsy. So this condition is called as neonatal asymmetric crying faces. So it is when you say this, the nasolabial folds and forehead wrinkle, when you see it's normal, then you can label it as neonatal asymmetric crying faces. The etiology could be because of the four muscles which are responsible for depressing the lip. So out of all the four muscles, the depressor angularis oris and depressor labii inferioris muscle are the most commonly involved, almost accounting for 80% of it. Mentalis and platysma only minorly involved. So reason could be either congenital absence of the muscle, or there could be a problem with the nerve. It's a peripheral branch of the facial nerve supplying this muscle. So how do you confirm this? If required, you can confirm it using ultrasound or MRI or CT just for looking at the muscle. And these babies do not have feeding issues. None of the literature so far has reported a feeding issue with this problem. But the problem is these babies can have some association. So they could be associated with congenital cardiac disease, mainly PDA and AST and VST. That's called as Kayler syndrome. And they could be association with the Dijot syndrome. So you have to do a calcium for this baby, and probably other associations which are rare like neuroblastoma and neurofibromatosis, but you have to keep in mind all this. And coming to our facial nerve palsy, now we know how to differentiate which is a facial nerve palsy, which is not a facial nerve palsy. So coming to the discussion part, facial nerve palsy occurs in about 1.8% of the live births. It is really a problem because for doctors, we are concerned with the etiology and treatment options and whether what to treat, what to use, all that. In parents, the parents' concern is absolutely different. Actually, see, this the first baby, when we had to counsel them because of the bleed, because of the sepsis, because of the shock, they were not worried. The mother's worry was, will my child smile back normally? For them, the concern is more of cosmetic rather than this one. So all these we have to address. So facial nerve palsy is definitely important. So now a proper history and a thorough examination will help us narrow down lots of etiology, and it will help us investigate easily. So when you have facial nerve palsy, first thing you have to ask yourself whether it is present since birth or it's acquired later. So if it is present since birth, whether it is, you can see acquired can be present since birth because of trauma. So you can go through the risk factors of, you can, do a checklist of the risk factors of the trauma, and you can see if that is there, probably this could be traumatic. Or if that is not there, if it could be developmental. Developmental, again, it could be isolated or it could be associated with syndromes. The ones which are acquired later could be various etiologies like IC bleed, infection, mass, or idiopathic. So when it comes to traumatic facial nerve palsy, it's a most common etiology. Almost up to 90% of the facial nerve palsies are because of the birth trauma. There are a number of risk factors, but the most important one I would like to highlight is prematurity. So we all assume LGA babies, instrumental babies, all that we all know. It's logical, but I didn't know until I was preparing the slide that prematurity is a risk factor for a traumatic facial nerve palsy. And now, traumatic facial nerve palsy is actually very good for the babies. Babies resolve spontaneously within 4 months, almost 100% of the cases, but it is not good for our OBG colleagues. So a lot of medical legal implications when you label and tell it to your attendants. In India, not even medical legal, your parents would just run and jump on the OBG colleagues. So it is important to counsel them properly as well regarding the traumatic facial nerve palsy. And now coming to developmental facial nerve palsy, it could be associated with a number of syndromes. You can get this list on any case report. You can get this list online. This is important because if you see a facial nerve palsy with an abnormal features, probably you have to rule out one of the syndromes. Like Mobius syndrome, it would be associated sixth nerve palsies. Myotonic dystrophies, it will be associated neuromuscular disorders, and you'll have hypotonia, you'll have respiratory problems, all that. You have golden hair syndrome, where you have developmental anomalies of first and second arches, like and other facial anomalies like ear anomalies. So all that you'll be able to rule out based on your syndromic features. And the problem with developmental facial nerve palsy is the prognosis is very poor. They do not resolve. So you'll have to come up with an alternative form of treatment for them. And there is an isolated form of developmental facial nerve palsy also. It could occur because of hypoplasia of the nerve or the nerve nuclei, or aplasia, or the nerve in the ear canal traverses through the bony canal. Okay, that bony dehiscence would be there, would put this nerve at a risk. So there is some genetic implication also, where the hereditary congenital facial paresis 1 and 2 are associated with the mutations in the chromosomes which are mentioned here respectively. And now coming to acquired. So acquired can be present with meningitis, ear inflammations, IC bleed, cerebral edema, idiopathic. So our main focus would be dealing with only idiopathic, because the rest of the etiology is you treat the etiology, the palsy will resolve. Just before going into the idiopathic facial nerve palsy, I would just like to highlight a little on the course of the facial nerve and upper motor neuron, lower motor neuron differences. Just brushing up, I'm sure all of you would be knowing this. The diagram, what you can see here is only the element, the course of the facial nerve below the nucleus, from the nucleus. From the precentral gyrus to pons is not shown here. So from pons to this facial nerve is again divided into three parts. One is the intracranial part, which comes from pons. It leaves at the cerebellopontine angle and it enters into the internal meatus. So in the meatus, again, it has the meatal part. Within the meatus, it has a labyrinthine part, which is the most, this part is most likely usually affected. And then this ends in the genu. After the first genu, you can have a horizontal segment, which is the tympanic part. You get another turn or genu, and then you get a vertical part, which is a mastoid part. After that, it comes out of the cranium. That's called the extracranial part, where at the stylomastoid foramen, and it supplies the facial muscles. So this picture we have been learning from our third semester MBBS postings. So what is LMN? What is UMN? So the only thing, just all of us know that LMN would be one side of the face completely affected. UMN would be the upper part of the face is spared. And this is grading of the facial palsy. This is a scale called House-Brackman grading. So it is, you have to examine at rest. You have to examine when the patient is active. So initially, most commonly first affected is your nasolabial fold. Next would be your forehead, and then you will get involvement of the eye, and later you will even have involvement at rest. So asymmetry at rest is a severe grade, that is grade 5. Actually, it is better we start using all this, because for standardization. So there are many case reports on facial nerve palsy which say baby has improved, but we really do not know if we can say from grade 5 to grade 2 we can document improvement. The same thing with our first case also. I've just mentioned partial improvement, but I didn't apply the scale because it is very difficult to apply the scales in neonates and children because they do not cooperate with you. And there's another scale also from Japan called Yanagihara scale. It's a 40-point grading system, which is an even more complicated one. So now coming to our discussion, it is idiopathic facial nerve palsy. So you call it idiopathic because you still do not know the etiology, and most probably it's viral infection, suspected pathology, and vascular insults. So Bell's palsy, when do you call it Bell's palsy? It's an acute onset. It should be a unilateral one. It should be an element palsy of unexplained etiology. So it's a rare phenomenon, and again, the diagnosis of exclusion. So this is a paper published in BMJ case reports, where it's an idiopathic facial palsy. They have attributed the etiology to CPAP. This was been published by faculty from SGPGI, Girish Gupta sir and Akash Pandita sir. So they assume that the strap, you can see the CPAP is fixed with a mask, and that is strapped, and the strap goes under the ear. So this is where the facial nerve exits the stylomastoid foramen, and in babies, the bone is not completely ossified and puts the facial nerve at risk for compression. It's a very, very good thought, but two things what we cannot explain here is, one, all of us use CPAP left and right. We would have used lakhs and lakhs of CPAP, but this palsy is not reported in everybody. And number two, how do we explain unilateral? Because the strap goes bilaterally, why doesn't put pressure on the other side? So, but probably this is, all these are research questions, and if we have good data, probably we'll be able to standardize things. And now just coming to imaging in the Bell's palsy, there are no, again, uniform guidelines for imaging. So when we ask for a CT, the CT recommendation is actually for pediatric population. So when you have a history of chronic otitis media or otoscopically demonstrated mass or previous mastoid surgery or temporal bone fractures, then you get a HRCT with the focus on temporal bone. You do not have any of that, then you get a pre and post contrast MRI with involving brainstem, parotids, temporal bone. All these cuts needs to be asked. Okay, and just to know, contrast enhancement of the first genu and the proximal tympanic segment is considered normal. So many of us see that contrast enhancement and we assume, okay, this is something abnormal. And in Bell's palsy, you can have contrast enhancement of the geniculate ganglion within the labyrinthine segment. And now coming to the biggest question, steroids and Benz palsy in neonates. So what is the rationale? Steroids reduce inflammation, so probably it decreases compression, and it'll help in regeneration. But we all know steroids is a double-edged sword. If you do not swing the sword properly, you can enjoy yourself. So you will have to weigh your risks and benefit before opting for steroids. So one school of thought is neonates have a very small facial nerve. When the cross-section of the facial nerve is small, edema will not affect it much. So they say no steroids. Another school of thought says, okay, no, regeneration of the facial nerve is better in neonates, so we give steroids, it would improve better, so we have a role of steroids. So this is always debating. So I mean, it's the debate continues, and we need evidence to prove anything in the current day scenario. So if we go through the evidence, there is paucity of evidence in neonates, as we all know. 1 or 2 case reports say you use steroids, baby improves quickly. The maximum or the quickest improvement is 6 weeks, what we have seen. And so we have to derive evidence, rely on the evidence of pediatric and adult population and try extrapolating it here. So the American Academy of Neurology guideline says in adults it's good, in pediatric we do not know, it's inconclusive. And the Cochrane 2010 review also says it shows good benefits, but out of the 8 studies, only 1 had pediatric population, and there was no infant in that population. So this is a systematic review which includes 6 studies. It's a very busy slide. So of these 6 studies, the first 3 studies have a neonatal population, okay, but not many. If you can see, I mean, there's a lot of heterogeneity in these studies with respect to the steroid use, the protocol used, how many days it was given, and how the injury was graded. Few followed House-Brackman scale, few followed Yanagihara scale, few said it's only clinical evaluation without scale, and the follow-up time was different. So, but this was the only literature available so far. So there is a lot of variability and heterogeneity. We cannot conclude on still anything. As of today, the steroid, we do not know. It is an individualized approach. You make sure you're not doing harm to the baby. And you select your patient properly. So coming to the antivirals, the story is same again here. Initially, in the initial studies, they thought antivirals did not show any benefit. Later came studies which said antivirals plus steroids were beneficial over just steroids. But now the current 2019 meta-analysis says when you compare antivirals plus steroids against steroids, it is not much beneficial. So keeping in mind, antivirals also do have a lot of hepatic injury. So you really use it only when it's really required. And electrophysiological studies. So these tests are useful to differentiate between neuropraxia and degeneration and help predict prognosis also. There are 2 types. One is electroneuronography. This is actually done within 1 month, best done from 1 week to 3 weeks. Here, what you do is the facial nerve is stimulated, and you compound the action potentials and compare it to the normal side. So if your action potential is diminished by 90% within 14 days, it shows poor recovery. And next, coming to electromyography. This is actually very good. I mean, this is done when you're if this is indicated if baby do not show any signs of improvement in 3 months. So before going for surgery or planning your further treatment, you need electromyography done. So in this, there are 2 concepts. One is, I mean, here what you do is you put electrodes in the muscles, which is usually orbicularis oculi, orbicularis oris, and record their potentials at rest and voluntary contraction. So you have 2 potentials. One is fibrillation potentials. So fibrillation potentials are seen in denervated muscles, we all know. And then something called as polyphasic reinnervation potentials, which are the earliest sign of recovery. So before you plan your further treatment, you see for these 2 potentials. So if you see polyphasic potentials at 3 months of 3 months of the facial palsy, it gives you reassurance that okay, the nerve is recovering. Probably we can wait for some more time. If you see fibrillation potentials without polyphasic potentials, so it tells you there is no recovery, but there is fibrillation potential. So my motor end plate is intact. I mean, the only treatment I need to do is just substitute the nerve. Nerve grafting is enough. And if there is electrical silence, it tells me all my motor end plates are atrophied. So if I have to plan treatment for this baby, then I'll have to put a nerve muscle graft. And this, I just found it fancy. It's just like our Ayurvedic and Unani. Chinese also have this traditional method, acupuncture. All the studies, 13 studies, what you see here in this study are Chinese studies only. And the smallest baby was 6 years old, and they have not seen any benefit with acupuncture and facial nerve palsy. And coming to the surgical approach, so surgery is done for permanent facial nerve palsies or developmental facial nerve palsies which have not improved. You cannot get back the full function. It might just help in a little. There are two procedures. One is static, which will provide symmetry at rest. One more is reanimation technique, which will give you, let you smile, let you have a good facial expression as well. So as we already spoke, there'll be muscle transfers, nerve crossovers, cable grafts, and free muscle grafts. Many are done based on the evaluation. And most important part of facial nerve palsy is eye care. So we usually tend to forget this. Even if we remember it also, it's very important to counsel the parents properly. So when you put eye care or eye patching, most important is you tell them it is not continuous, because if you put continuous, it will take away the stimulus for the baby and it will result in amblyopia. So you have to put lubricating eye drops, eye gel, and eye patching, preferably when the baby is sleeping, and leave it open when the baby is awake. And in very severe cases, when it is not recovery and there's a lot of corneal damage, then you would go for tarsography. Another biggest challenge for us is feeding issues. Both the babies with what we had with facial nerve palsy had feeding issues. So you have to come up with some other modality and try and make sure you give them mother's own milk, whether it would be spoon feeds or your syringe feeding or you use feeding tubes, all that. So, but this is a big challenge for feeding babies. And coming to prognosis, so again, this is like you can first see the picture below. The white one is axon, the yellow one is a myelin sheet, and neurulum and endoneurum. So all the multiple nerves are packed under one sheet called perineurium, and entire nerve is enveloped with epineurium. So you can see the degree of injuries. So it's only functional block. There is no morphological anatomical problem. So you call it neuropraxia. Loss of the axons, but your endoneurium is good. You call it grade 1, grade 2, or it's called as accentemesis. And your endoneurium is damaged. You call it neurontemesis. Your perineurium is damaged. Then you call it 4th grade, and your entire cross-section nerve is gone. You call it 5th grade. So more the severity, obviously the prognosis is poor. And coming to this, I mean, developmental facial palsies, as discussed already, have poorer prognosis because they do not recover. And traumatic facial palsies are excellent. Almost all the literature says 100% recovery by 3 to 4 months of age. And clinically incomplete lesions tend to recover. So House Brackman stage 2 and grade 2 and grade 3 tend to recover better than grade 4 and grade 5. And if the baby starts showing some signs of improvement within 3 weeks, then the recovery is bound to happen better. So these are the take-home messages. It is very important you differentiate your developmental facial palsy and traumatic facial palsy, because it's easy to counsel your parents, reassure them, and you can have a good concrete treatment plan. And idiopathic facial nerve palsy, what we had 2 cases were all diagnosis of exclusion, and no established role of steroids till date. So you have to be very judicious and case-based, keeping in mind our tiny humans. And further evaluation, surgical consultation, plastic surgeon consultation is required if facial nerve palsy persists beyond 3 months of age. And parents must be told and highlighted about the importance of the adequate ophthalmic care and feeding issues, and try to establish mother's own milk. So I would just end saying that all our babies with asymmetric faces, I hope all of them tend to have such a beautiful and cute smile. Thank you. And we are open for discussion now.
Yeah. I think we have another 4 more minutes. There was one a question in the chat box about facial nerve palsy following the CPAP. So as Kalyan discussed, there are case reports where they have attributed the facial nerve palsy to CPAP strap. But we didn't have that type of strap type of CPAP, but still it could be one of the cause. But since we usually have so many babies which are put on CPAP, we thought it could not be due to CPAP. It could be idiopathic facial nerve palsy. We had a problem with establishing feeding in these babies. So otherwise, the second was active, but we took lot of time to counsel the parents and establish feeding for the babies. So any inputs from the group, we are welcome.
Somebody in the chat box says, actually Sukina ma'am, she says facial nerve palsy has been reported with prongs. I have gone to the literature. It was only, I mean, I could only find it with the mask. Prongs, I didn't find it anywhere. Probably you can share it with us, ma'am, if there is any case report or anything with the prongs.
And we have to know how to differentiate facial nerve palsy and depressor angular oris, because in depressor angular oris, we don't have any feeding issues. Baby will be otherwise okay, but we have to rule out other associated congenital malformations like congenital heart disease.
There's
So
another
we have
question.
already discussed how to differentiate depressor angular oris and facial nerve.
Yeah, there was another question on how to establish feeds for these babies. So initially it would be tube feeds only, and later, you can come to spoon feeds, provided you start. I didn't put my slides on facial now. Facial massage. So it was advocated for one of the baby from a pediatric neurologist. So probably it would have helped my our baby, because the baby started taking spoon feeds after doing this facial massage. Not sure whether it is just a bias or really it helped, but probably we can try all that. So spoon feeds or syringe feeds if it is not improved, if it cannot take.
Kalyan, there was one more question on EMG, whether you did or not.
No, EMG was not done for any of the baby, because first baby improved quickly. The second baby, it's showing partial improvement. MRI was done. MRI shows normal. Even the Fiesta sequences were also taken to see the facial nerve, and even the Fiesta sequences are also normal. We just have a plan. We are following up the second baby. The second baby does not show complete recovery by 3 months. Probably we will be going with EMG studies. Any other questions?
Any other questions? Because we have 1 more minute. Kalyan, we can unmute Alimelu madam is there. She wants to talk anything. Madam?
Ma'am can unmute herself, ma'am. I do not know how.
Dr. Usha is there. Dr. Usha?
I've asked ma'am to unmute.
Yeah. Dr. Usha?
Ma'am, our time.
Kalyan, you got.
It's less than a
Yeah,
minute.
yeah.
So
I think it will get over. Yeah.
So
if there is no other question, I think we can.
I thank
stop.
everybody for their patient hearing. If there are any other questions, you can post it in the Telegram group so that we'll try responding. Thank you. I'll end this slideshow.
Yeah. Thank you.